Okay, so hope you had a good lunch. The students here and I went out to, Five Guys?
Yeah.
And so we ate too many burgers and too many fries, so anyway. Looking at this afternoon to walk you through everything. We're going to go another 2.5 hours here, be done by 4, but I've reorganized it on the modules. I posted the video from this morning. So we'll look at the end of Module 5, and you can look at this on your own time, but this will fill out the class. There's a DSM-5 overview video of the DSM-5 I find very helpful, rather than just put that on slides. And so then I'm making some changes here in real time. So this afternoon, we will finish out these. We'll get through as many as we can, but neurodevelopmental disorders. And had a question earlier, I think it was Alicia, about how some of these interact, for instance, autism and things like that. We'll get into that. Then the next session will be depressive disorders, and I split that up from anxiety to spend some time there. Then schizophrenia and bipolar disorders, and then trauma and stress-related disorders. Okay, so try to get through 4 sessions. It's going to be a lot, but we'll do the best we can. Then, if you'll notice, under Module 4, there's case study, okay? And if you click on case study choices, okay, that's beneath there, then there's the document that you can choose one of the cases to do your paper on. Okay, I believe it's 4 pages. Kevin mentioned earlier, I think, I didn't think this through, but it's a good observation. Copy and paste the case study into the paper. I'll give you a benefit here. It can count as part of your paper. And so there, you got that. So we kind of know, I know which one you're dealing with. And here's the deal. I'll say this. Diagnosis is not an exact science. There's comorbidity, things like that. So, but do the best you can. And I just want to see you're thinking through it. And that you do some research for like treatment. But if you're just completely lost and there's one, if you'll just email me and say, this is what I think it is, and you're one of those students that has to get it, I'll just give you the answer and tell you which one it is. I'm not trying to trick you here, trying to help you. So that's the case study choices. And then tomorrow, 8:30 a.m., probably till 1 o'clock, Doug will be here. And eating disorders use, he'll go through interviewing, a little bit of a treatment to make it practical about the questions you would ask. And then session 17 is personality disorder, and have him spend some time on that. And that's the one that usually interests people a lot. That's when you're getting into your borderlines and your narcissism and all these things that we talk about. But that's kind of how this is laying out. So anyway, but moving forward here, neurodevelopment disorders, okay? So, kind of just a little pause here, DSM-5. To improve clinical utility, the DSM-5 is organized on a, change it so you can read it easier, developmental and lifespan considerations. It begins with diagnosis thought to reflect development processes that manifest early in life, so neurodevelopment, schizophrenia spectrum, and other psychotic disorders, followed by adolescent and young adulthood, bipolar, depressive, and anxiety, and then ends with diagnosis relevant to adulthood or later life neurocognitive disorder. So there is a reason for the order. A similar approach takes place in each chapter. A comprehensive use of lifespan information as a way to assist in diagnostic decision making. So the whole thing lays out that way, and then by chapter. So here we go. A mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion, regulation, or behavior that reflects a dysfunction in psychological, biological, or developmental processes underlining mental functioning. Mental disorders are usually associated with significant distress in social, occupational, or other important activities. And Doug will mention this tomorrow again, the difference between zebras and horses, okay? The use of the word significant, meaning a lot of times people are going to come for counseling and they might be struggling with anxiety or they might be struggling with depression. They're the ones who get to decide where you go in treatment. And so you're not going to have to necessarily make a DSM-5 diagnosis, okay? So you don't have to put the square peg in the round hole, so to speak, okay? An expectable or culturally approved response to a common stressor or loss, such as death of a loved one, is not a mental disorder. Socially deviant behavior, political, religious, or sexual, and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction in the individual as described above. So if somebody does something very deviant that we consider horrible, it's not going to be a disorder unless it's linked to that. Now, what do we want to do in our current society? Find a reason for everything. You know, and I understand that, and a lot of times that's going to be present. But can people just do deviant things? Yep. You know, David had one of his good friends and generals murdered, killed in battle. What was his deviant behavior? Murder. What was his mental disorder? I don't know if he had one. I think it's the old-fashioned one of you really mess up and the lengths you'll go to cover your tracks is huge. I mean, people kill for jealousy. People kill for revenge. People kill for greed. People kill not to get in trouble. That doesn't necessarily mean you're depressed, anxious. Doesn't mean you're defiant. It's like oppositional dysfunctions. It doesn't mean any of that. It just means we'll do things for the most base of reasons. And so.
And not to say too that not saying murder's okay.
Yeah.
I'm not saying it's right, but he wasn't a murderer. Like he wasn't going on like killing sprees and murdering people.
Yeah, it was very intentional. Oh, absolutely.
You know.
Yeah. Yeah, there was an advantage to him to do that.
Yeah.
And so, yeah. And how many crime movies do you watch? What lengths will parents go to save their children? It's an unreasonable love at times. Oh, yeah. You know, we hate abortion. Rightfully so. Imagine good people having abortions when pushed to, wait, do they forget? No. What they'll do to save face from shame, to manage their life. I mean, we make poor decisions not because of disorders in the DSM-5, just because that's our nature. We're fallen. So, neurodevelopment disorders. So here we go. Autism spectrum disorder, social communication disorder, attention deficit hyperactivity disorder, intellectual disability, and specific learning disability. Okay, so that's kind of our overview here looking at this. So DSM-5 splits childhood disorders into two chapters: neurodevelopment disorders and disruptive impulse control and conduct disorders. And the DSM-5 combines some disorders: autism disorder, Asperger's disorder, persuasive developmental disorder not otherwise specified, combined into autism spectrum disorder. Now, I think it was Alicia that had the question, okay, where do they relate? Why is there overlap? But it is in the same section, okay? So we're looking at some of the, you know, and Asperger's is kind of unique because it's not technically, it's kind of new coming into the field. But you look at it and you think, well, could severe cases of autism spectrum disorder also overlap with opposition, things we talked about in the earlier session, right? And rightfully so. Also, depending on the age, you know, where they're going through that, and do they exhibit some of the same behaviors or signs, if that makes sense. So that's why comorbidity can exist there, and that's why you can have multiple diagnosis and symptoms, but this kind of gives you an idea of how that all fits together. Neurodevelopmental disorders changes in DSM-5. intellectual disability disorder replaces the term mental retardation, severity determined by adaptive functioning rather than IQ. And just, and to be speaking scientifically here and just culturally correct, you won't hear the word anymore, retard or retardation anymore. And DSM-5 changed that as well. Communication disorders renamed, introduction of social communication disorder, okay, more pragmatic in the definition. ADHD, onset of symptoms by age 12 rather than 7. And then reduction in number of needed symptoms for adults, 6 for children under 17 and 5 for individuals over 17. Now, just tell me, I will give you the answer for sake of time. This means it's probably easier to diagnose somebody with this. Fair enough. But also, we've kind of raised the age for onset of symptoms by. And what could have been the benefit in doing that? Maybe some overdiagnosis at too young of age that, when things were happening. Then specific learning disorder merges several disorders from DSM-4. Okay. If you're not familiar with the DSM, some of this might not be interesting, but that's what's changed. So neurodevelopmental disorders, there's been a move away from relying exclusively on IQ scores and toward using additional measures of adaptive functioning. Okay. The DSM-4 criteria had required an IQ score of 70 as the cutoff diagnosis. The new criteria recommends IQ testing and describes deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. So they're kind of looking at it through a new window here rather than just an IQ test, okay, which they relied on heavily. So with that, I'm going to switch this over to make it easier. So here's the big ideas with this. A child's brain is not a miniature replica of an adult brain, but rather a brain in continual development, growing at times tremendously, subject to endless modification and connections due to the continual stimulation provided by the environment in which it develops. Okay? If you remember normal human growth and development, for Kose remembers it because he took all the classes, it isn't until early to late 20s that our brain is completely developed. As mammals, it takes the longest. We talked about that and how that relates to the image of God. I'm not going to review that. It is essential to understand the development of the nervous system and its different stages in order to understand the deficits that can arise from abnormal brain development or be caused by damage at an early age. Depending upon the time when these abnormalities or damage occur during pregnancy, or infancy, childhood, prenatal, the impact of the individual will vary. Some of the disorders included in this classification can be completely resolved by appropriate intervention. Others are chronic, but an adequate intervention is nevertheless essential because it is possible to alleviate to a greater or lesser extent, and in some cases eliminate, the negative consequences or symptoms caused by the disorder in question. Okay? So that's some overview. So we'll begin with some of the major ones, looking at it. Autism spectrum disorder, okay? ASD. There are a group of developmental disabilities that can cause serious and even chronic socialization, communication, and behavioral problems. There was a show on years ago called Parenthood. And it's a real, it's one of those shows that makes you cry at the end of every episode. Family. It's not a Christian show, but Max is the young child in it that does have autism, and I think it does a real good job showing the frustration of the family and the challenges and what's available and whether you mainline a child in school and a lot of those things. So anyway. The way in which these changes are manifested varies greatly from child to another, hence referring to a spectrum or continuum of disorders. Okay? So there's a spectrum within this. The The clinical profile is neither uniform nor absolutely demarcated. It oscillates, ranging from high to low effect, varies with time, and is influenced by factors such as degree of associated intellectual ability to access to specialized support. Okay, so we have a range of disorders here, and I have quite a few counselors that are, not quite a few, seems like quite a few, that this is becoming their specialty. Like even in play therapy to deal with children on the autism spectrum disorder continuum. So people with ASD process information in their brain differently than others, and they develop at different rates in each area. They present with clinically significant and persistent difficulties in social communication, marked difficulty, and I think this is important, in nonverbal and verbal communications used in interactions, lack social reciprocity and difficulty in developing, maintaining peer relationships appropriate to their developmental level, stereotypical motor or verbal behavior, unusual sensory behavior, and excessive adherence to routines and ritualistic patterns of behavior, and limited interest. Very eccentric, very focused in those things. It doesn't mean they don't excel at some of them, but they're not going to be reciprocal in affection giving to them in some cases and things like that. So what is this autism spectrum? It's going to consolidate prior diagnose into ones, and Rhett's disorder. Deficits are now characterized in two domains: social communication and social interaction, previously separate domains, and repetitive behavior. Deficits should be present in the early developmental period, but cut off by 3 years of age eliminated. And severity included specify requiring support, requiring substantial report, or requiring very substantial report. Okay, so just like the other ones where it was low, mild, high degree, and this is at the very beginning, if you remember when I went through the DSM-5, meaning it's moved away from this or that, absence or presence, to continuum, which is actually a better way to make diagnosis and gives you more freedom. 2 symptom domains, I think here: social communication and interaction deficits, and restrictive repetitive behavior. And they can be met currently or by history alone. Inclusion of specifiers, primary diagnosis, followed by a number of these that go into it. So those are your symptom domains. So severity levels of autism spectrum disorders. So, and this is going to be very important. It'll be important if you're working with families, whether students are mainline education, right? Or whether the student is held out of school or provided a special education environment. It'll determine the level to which they're going to interact in activities, things like that, the support that are needed. Can the parents do it? Things like that. But level 3 requiring very substantial support. Okay. Level 2 requiring substantial report, and level 1 support. You say, well, that's very ambiguous, and yes, I get that. But that's the idea of the spectrum, is providing help and things like that with it. So what does this look like? And let me switch this over so those watching online can have a better shot. Level 3 is the toughest. Okay? And let me just say before this gets into the deep stuff. This is common. You'll be dealing with families if you have any breadth of influence in your ministry. So, and you might be taking this and you're just a pastor. It means the world if to some degree you can speak intelligently or with some degree of education with families. Okay, to just ask a few questions. Okay, so level 3 requiring very substantial support. Severe deficits in verbal and nonverbal social communication skills cause severe impairments in functioning. Very limited initiation of social interactions. Minimal response to social overtures from others. For example, a person with few words of intelligible speech who rarely initiates interaction, and when he or she does, makes unusual approaches to meet needs only and responds to only very direct social approaches. So you can envision this person. Restricted or repetitive behaviors, inflexibility of behavior, extreme difficult coping with change. Could be breakdown, emotional breakdowns, or other restrictive repetitive behaviors markedly interfere with functioning in all spheres. Great distress, difficulty changing focus or action. Okay, so I put with those things. I look at requiring substantial report, marked deficits in verbal and nonverbal social communication skills, social impairments apparent even with support in place, limited initiation of social interactions and reduced or abnormal responses to social overtures from others. For example, a person who speaks simple sentences, whose interaction is limited to narrow special interest, and who has markedly odd nonverbal communication. So what does it look like with repetitive behaviors? Inflexibility of behavior, same as above. Difficulty coping with change. It doesn't mean extreme difficulty, but it's not going to be easy. Or other restricted repetitive behaviors. In a variety of contexts, distress or difficulty changing a focus. And then you have level 1 requiring support, the lowest on the continuum. Without supports in place, deficits in social communication cause noticeable impairments. But the key there is what? Without support in place. Okay? So now we're into how you would help the family member, help the client with what support makes this easier. Okay? Difficulty initiating social interactions and clear examples of atypical or unsuccessful responses to social overtures of others. May appear to have decreased interest in social interactions. What do you take from this? May appear. It means it's not that they don't. It just means the social cues aren't there. It doesn't mean they're not. That's what changes. For example, a person who is able to speak in full sentences, engage in communication, but whose to and fro conversations with others fail, and whose attempts to make friends are odd and typically unsuccessful. This is important. Attempts to make friends, they are attempting. They just don't know how. So what could help within an environment here? Family members intuitively will learn what's going on. Can a peer group be created through the therapeutic process with those who understand this is what's happening? Does that make sense? Mm-hmm. And so I think that helps. Inflexibility of behavior causes significant interference with functioning in one or more contexts, and difficulty switching between activities. Problems of organization and planning hamper independence, if that makes sense. So, anyway. Next is going to be a social communication disorder. Okay. Social communication disorder, persistent difficulties in the social use of verbal and nonverbal communication is manifested by all of the following. Okay. Deficits in using communication for social purposes, such as greeting and sharing information in a manner that is appropriate for the social context. Impairment of the ability to change communication to match context or the needs of the listener. Inside versus outside voice. Okay. Difficulties following the rules of the conversation and storytelling, taking turns, rephrasing when misunderstood, and difficulty understanding what is not explicitly stated. They can't pick up on what's implied. Okay? So when all of these are manifested within this disorder spectrum, we have social communication disorder. Okay? And like I said, you go through these in the DSM-5 in greater detail, but to be familiar with what's happening here. Deficits result in functional limitations in effective communication, social participation, and academic achievement, or occupational performance. So will this affect school? Most likely. Yes. Most all social activities and things happening. And we always have symptoms are not due to another medical or neurological condition or low abilities in word structure and grammar, and not better explained by the ASD and intellectual disability. Okay, so must be present in childhood even if the symptoms are not recognized until later. Okay, and so it takes a while sometimes with these things to see how they're developed, if that makes sense. So anyway, here's one. Then will you check the temperature in this room and knock it down and set it over there? I don't know, it just feels a little warm. For all of you watching online, I'm sure you're in your, I don't even know if you're in air conditioning yet this time of year, so anyway. Just take a second here before we pull the other one up, so see if we have anything going on with,
It says replace battery as I'm trying to push it down. Replace battery. It's set to 55 though.
oh, you're good.
Indoor saying 75 though. But it's not working. It's not working. It's not letting me. I'm gonna go to the bathroom.
All right, so attention deficit hyperactivity disorder, very well known in our society, very common. During the 1980s and 1990s, approximately 50% of all children referred to outpatient mental health treatment clinics were referred based on concerns about possible ADHD. Okay? 3 to 5% of school-aged children in U.S. struggle with ADHD for DSM-4. Considered a lifelong disorder, approximately 70% of children diagnosed with ADHD will struggle with symptoms throughout life. Okay. Now, is this overly diagnosed?
Yes.
Yes. Okay. I think there's some good research on that. I think we live in a healthcare system. You don't want me to get into that too much, but doctors are overworked, and they don't have the time to meet. I think you have skills not given to parents to the degree that could be, to inform, to help them decide. Too much Google diagnosis online, okay? And to be honest, medication can really help in some situations and it's needed. But a couple of things get in the way there. One could be, are we medicating to make life easier for parents instead of what's in the best interest of the child? And something else that factors in, is it just too easy to diagnose and give out medication now? That possibly could be the case. At the same time, I think you need to be careful with the other extreme, that if medication is really what could help the child and it's withheld because of stigma or shame, or I was counseling a guy, man, and his son had a speech impairment, and it was severe, and it was causing difficulty with social interaction and things. And I can remember at the very beginning, it was emotionally difficult for him. Great dad, a believer, intentional about his walk with the Lord, things like that. But boy, he just did not want to give himself over to the fact that his son had a problem and then go down that path. So we'll try everything in the world. And he did a lot of work, and I met with him a long time. And it was interesting the other day meeting with him. He's working with me on something else. And I could just tell kind of a piece that he'd come to terms with the reality. And then because of that, okay, we need to do whatever's in his best interest to get him help. And, kind of overcoming the denial part and things like that. So the only reason I mention that is, everyone has all the stereotypes, and someone can say, well, this is diagnosed too much, too little. You're guiding, you're the counselor, you're guiding the parent usually in these situations to make the best decision for their child based on the information. And what's going on in the rest of the world is not what your concern is when you're going through counseling. So anyway, you're the encourager. So diagnosed more frequently in boys, almost 4 times as much. I think there's an intuitive answer for that. Okay, rambunctiousness.
Yeah.
Boys externalize symptoms, whereas girls internalize symptoms. Now, this is important. Both could have it, but it'll be more easily diagnosed because the boy is going to give you the presenting problem. Where the girl, the young lady, you might have more difficulty with it. It might be present, but they just internalize it. So it's not as visible, or it's going to be projected in different ways. Okay, so anyway. No single cause explanation for the cause of HDAD has been identified. So, possible explanations include neurobiological irregularities, neurochemical irregularities, environmental toxins, diet, and family factors. Okay? So here enters an entire other world, okay, about the biological basis. And I won't even get into that, and you notice none of your papers have that assignment, because enter the controversy, if that makes sense, wars of everything. It is evident that neurological deficits are part of the symptom pattern, okay? That is, with it, so. So, ADHD, 2 symptom domains, inattention and hyperactivity impulsivity. Okay? So, one is inattention, they're checking out. It's staring out the window. At school, not paying attention. One is the hyperactivity or impulsivity. So, it used to be just attention deficit disorder, right? ADHD, attention deficit hyperactivity disorder. Okay. At least 6 symptoms in one domain are required for a diagnosis. Persisted for at least 6 months to degree inconsistent and developmental level with negative impact on social, academic, and occupational domains. Okay. So, examples have been added to the criteria and item items to facilitate application across the lifespan. Okay. The onset's been changed from symptoms that cause impairment were present before age 7 to several inattentive or hyperactivity impulse symptoms were present prior to age 12. Why do you think this changed? Just think of it intuitively. A couple of things going 2 ways here. You can kind of tell what they're trying to do, the experts. They're recognizing that the symptoms might not appear until after age 7, okay? Or they weren't observed, right? And several inattentive or hyperactivity. Several. Why do you think they're adding that word several? People too quickly diagnosing. Let's be sure with children. Are all children going to be a little hyperactive? Yes. Oh boy. My grandson's 5. A lot of energy there. Sometimes he's just running around. Sometimes he runs into walls for fun. Okay, so he's playing. So anyway. Symptom threshold has been made for adults as well. Comorbid diagnosis with autism spectrum disorder is now allowed. Other factors as well. So that was a question earlier. I think it was Alicia. Okay, with both. ADHD, inattention. So what's that? Fails to pay close attention to details, careless mistakes, often can't sustain attention, does not seem to listen when spoken to directly, does not follow through and fails to finish, has difficulty organizing tasks and activities, avoids dislikes and is reluctant to engage in tasks with sustained attention, loses things, distracted, forgetful. Okay, so the inattention part of the attention with that. Hyperactive or impulsive, okay? Not solely oppositional or failure to understand. Often fidgets, taps, or squirms. Leaves seat. Runs about and climbs. Can't play or work quietly. Talks excessively. Blurts out. Difficulty waiting turn, interrupts, and intrudes. Now, if you remember earlier, you had to have a high degree of these, right? You can't just pick one out. It looks like a child. But once again, you see the difference between diagnosing a boy and a girl, right, with presenting problems. If the girl's internalizing it, it can be coming out in different ways. But if the boy, in this context, making the point, is running around the room, can't work quietly, always interrupting, difficulty waiting in turn, fidgets, could the teacher observe that in a classroom setting? Absolutely. Okay. And so rather than always getting the child in trouble, so many safe chairs, so many timeouts, take a good hard look at this and see if something can't be done to help, or a treatment plan. Okay. But another lesson from Ephesians and Colossians on obeying your parents probably isn't, there's a lot more wisdom in this world than that. So you can also see the frustration, can't you? If it is a disorder. And our goal is to help people. So, okay. Criteria B to E. Several inattentive or hyperactive impulse symptoms were present prior to age 12. Several inattentive or hyperactive impulsive symptoms are present in 2 or more settings: home, work, school, and family. There is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning, and the symptoms are not better explained by another mental disorder. Okay? They're not better explained by something else. And then finally, intellectual disability. Okay, well, not finally, but 3 criteria must be met. Deficits in intellectual functions: reasoning, problem-solving, planning, abstract thinking, academic learning, and learning from experience. Deficits in adaptive functioning, remember maladaptive. Failure to meet developmental and sociocultural standards. Okay. Need ongoing support to participate in daily life. Onset of deficits during the developmental period. So here's where this can show up for parents especially, and it can be very painful, but you have the idea of the child progressing with friends and peers, and I think we already had it at our church, but there's a promotion Sunday where all the children move up to the next class, and all of a sudden they're lagging behind, or they're not progressing at the pace that they are expected to by the parent. So anyway, that happens. So mild conceptual domain, school-age difficulties in academic skills. Adults, abstract thinking, excessive functioning, planning, priority setting, and short-term memory. So you hear this phrase as kind of a cliche: people are over-functioning. Okay? And I don't want to, you can imitate, but sometimes that's considered, rude to do that. But it'd be like, well, anyway, I won't get into it. But social domain, difficulty in accurately perceiving pure social cues. Communication is concrete or immature for age. Difficulties in regulating emotions. Low awareness of social settings. At risk for manipulation. So practical domain, May need support in daily living tasks, grocery shopping, transportation, money management, etc. Recreational skills are similar, whereas the judgment and organization is lacking. And can procure employment in jobs that do not require conceptual skills. Okay. Moderate. School-age language and academic skills developed slowly. Adults, academic skill development at an elementary level. Okay. Social domain, ability to communicate or relate with others at a base level, can have successful relationships, may not perceive social cues, need assistance in life decisions. And practical domain, extended learning must take place for an individual to care for personal needs without assistance. Recreational skills are similar, whereas judgment organizational is lacking. Independent employment possible with lots of aid, and maladaptive behavior is present. Okay. Severe. Conceptual domain skills is limited and little understanding of written language, caretaker needed. Notice we're no longer discerning between children and adults. Speech may be single word or phrases. Social communication, understand simple speech and gestural communication. Relationships with family and familiar others are a source of pleasure. Practical domain requires support for all activities of daily life, bathing, dressing, elimination. Supervision at all times. Cannot make responsible decisions for self or others. Maladaptive behavior, including self-injury, is present in significant minority. What does this start to resemble that's consistent with old age? Some things people struggle with. Dementia.
Oh, yeah.
Nope. Yeah, looks like some of those things. So. Differential diagnosis, major, mild neurocognitive disorders, loss of cognitive functioning. Communication disorders and specific learning disorder do not show deficits in intellectual and adaptive behavior. And so autism spectrum disorder, social communication deficits. Okay. Intellectual disability, comorbidity. So here we go. ADD or ADHD, these go with it. Depressive and bipolar disorders. Anxiety disorders, autism spectrum disorders, stereotypic movement disorders, impulse control disorders, and major neurocognitive disorder. Okay, when you have more than one. So, next, some specific learning disorder. Okay. Following symptoms lasting at least 6 months despite interventions, inaccurate or slow and effortful reading, difficulty understanding the meaning of what is read, difficulties with spelling, difficulties with written expression, difficulties mastering number sense, difficulties with mathematical reasoning. Okay. You know, I remember I was in school. It's funny when you start to pay attention to things, and there would be a reading group. And all the kids would get together and the teacher would read to them. And I can remember at a young age, a young man, his name was John. I'm not going to mention his last name, although I still remember it now. And, you know, all of a sudden John wasn't in our reading group. And then John had a specific other teacher, I would not know what that was at the time, but, you know, to help with disabilities, would come into the class and take him aside and read with him. And, you know, back then, you know something's wrong, okay? You know something's not what it's supposed to be. But intuitively, I would see that he would struggle, and I'm young elementary, right? But what is the teacher recognizing? Now, it might have not have matched up with the DSM-5 it wouldn't have matched up with, but, you know, DSM-4, 3. But already we're seeing, you know, something. And it's difficult for parents, difficult for children. But our goal in counseling is to comfort. So I think this is a great example of the DSM-5. What sin issues are we dealing with here? We're in a fallen world. We are broken. There is weakness. Now, I don't mean to be facetious here, but yeah, and what Bible verses are going to help this child? Common wisdom will help. Okay? Getting help appropriate. So hats off to all the counselors who want to deal with autism spectrum disorder, ADHD, specific learning disorder, and want to go through training that is proven best practice. Okay, and so academic skills below age expectation interfere with performance or with activities of daily life. Learning difficulties begin during school years but are not fully manifest until demands outweigh individuals' abilities. And learning difficulties have nothing to do with intellectual disabilities, vision, auditory problems, things like that. And then specify with impairment in reading, word reading accuracy, reading rate, fluency, reading comprehension. So
This is the checkers game where grandson and granddad will bond.
take a break real quick for this. So I will post my PowerPoints for those watching online. So that was a video there on dyslexia and walking through that process. And so we'll be able to move through that. So specific learning disorder would be with impairment in written expression, spelling accuracy, grammar and punctuation accuracy, clarity, organization of written expression. With impairment in mathematics, number sense, memorization of arithmetic facts, accurate or fluent calculation, accurate math reasoning. So you can see it in the video. I know you couldn't see it online, but why do teachers catch this often when parents don't? They see the natural day-to-day. Okay, they see the progress that should be made and things like that. Mild, some difficulties learning skills in one or two academic domains, able to function well with appropriate accommodations, mainlining students. Moderate, marked difficulties in one or two domains, need specialized help to become proficient. Severe difficulties affecting several domains, unlikely to learn without ongoing intensive individualized help. Proficiency may be attained. I think what's interesting about this is they can be highly intelligent in other areas. Okay, you can see why, and I don't want to throw too much at you. Why did they move away from the IQ test? The IQ test realized it was more complex than that in these areas, so things like that. Differential diagnosis, normal variations in academic attainment, intellectual disability, learning difficulties due to neurological or sensory disorders, neurocognitive disorders, ADD or ADHD, and psychotic disorders. So I'll just give these to you. I think it's interesting. A 2-year-old boy presents following concerns that he is not yet using single words. He also seems disinterested in engaging with other children. He occasionally engages with his parents, but less than they think he should. He doesn't tend to look at them much, and they have difficulty maintaining eye contact with him. When he wants something, he pulls them to where the object is and screams. He doesn't point like other children. His parents have also noticed he doesn't play in the same way as other children his age. He tends to line up toys, plays in certain aspects of them, such as car doors. He doesn't use the toys in an imaginative way. He tends to become distressed when he thinks there's change around the house. In contrast, he's not concerned when either of his parents leave the house. Okay. I'm not going to put you on the spot there, but those could be case studies. So any guesses?
Autism?
A little bit.
A little bit there.
A 7-year-old boy is brought into the physician's office because of difficulty at school and behavior problems that started when he was in preschool. His mother reports that at home he runs around all day, needs multiple requests to pick up his toys, can only sit for a few seconds before growing bored. Teachers note states he cuts in line, distracts his classmates, loses his homework assignments, but is able to finish his work when given individual supervision. Mother's concerned because older children are teasing him for being stupid. However, she reports that he is a good boy who does not talk back to teachers or adults and does not bully anyone. So we don't have the social deviant, right? In the office, he's jumping up and down in the chair despite multiple requests by his mother to sit still. She notes that his 15-year-old brother was also hyperactive when he was young and has persistent academic problems. That's ADHD, okay? So anyway, all right, so let's take about a 10-minute break here, and then we will jump into depression, okay? All right, so depressive disorders. So we are on session 11. Okay. So this is the other one, obviously, with anxiety. I'm not going to belabor it with time, but anyway, once again, I will post the PowerPoints for those watching online later with all the YouTubes and things like that in there. So. Okay, so makes this tough if you're online, and you'll catch this later. I did upload the video, and so I encourage you to watch that one. It's Solomon YouTube if you just want to watch the TED Talk, and it's long, and it's not going to be fair to get into a huge discussion, but just quickly. So, what are your thoughts in class? And you'll watch it later. You might be watching it right now because I texted some of you. But what was your takeaway from that?
Well, the final word is like the opposite of depression is not happiness.
Yeah, it's vitality.
It's vitality.
Yes.
So that was a powerful word for me.
Yes, big takeaway.
Yeah.
Okay.
I'm a big fan of different phrases and kind of word plays. So the fact that he said the truth lies, I think, towards the beginning, and the fact that there's delusional perceptions that we kind of have and that we tell ourselves. And I just think that even in our depression, it's like we don't want to be the villain.
Yeah.
You know, no one wants to be the villain, but sometimes you have to accept that there's that part of us that is still our own worst enemy. That fallen nature, it's gonna be there, and it has to be addressed in some way. I think, and the first thing is to just accept the fact that you're lying to yourself and you need some help. And that's kind of what I think and I love that. I love the fact that he was talking about different alternative methods, and he wasn't really judging anybody for, hey, stand on your head, for 10 minutes. If it's working, then that's great. That's great. And so I don't know. I was a fan of that. It just seemed like he's done a real thorough investigation.
I always leave it. If you're online, I encourage you. Solomon, depression, TED Talk. I mean, you can just Google it and get it right there. I always leave kind of inspired because, and I think he really does a good job capturing what depression is. It's not just sadness. And he kind of differentiates. Here's sadness, here's grief, and here's depression. And grief could be I've lost somebody, and sadness could be a melancholy. But all of a sudden, depression is I don't want to fix lunch. It's too much work. I'll have to cut up the food and eat it. I don't want to leave the house. It's that we have in common with other people these existential thoughts that one day we're all going to die. But then the depressive person doesn't want to take a shower. And the other person still seeks to be vital in life and cherish it. And I just love how it captures that. Stigma is that we're all sad. Why can't you get over it? And he really does a good job talking about, why are some people more resilient and getting help and things like that. So I said in this morning session, anxiety is number one. Well, it only recently outdid number two now, which used to be number one, which is depression. So for time, diagnosing, and I did upload all three PowerPoints over on the modules. I put them under the Saturday afternoon module for everyone. So diagnosing depression and mania. Clinicians must consider numerous depressive syndromes, including major depressive disorder, persistent depressive disorder, depressive episodes of bipolar disorders. The opposite of depressed moods are mania and its variants. Once we have a diagnosis, we consider the question of comorbidity of mood disorders. And then depression shares borderlands with bereavement and other losses, problems with living, adjustment disorders, and also a question of suicidal ideation. I love the phrase in there where he talks about how it's not healthy to say a kid is inside because it's raining and can't play, so he's depressed, and that's the same word we use to describe someone before they commit suicide. And I do think our verbiage hurts, that people who are just kind of sad, well, I'm kind of depressed because I didn't get the job. Well, that's different than I don't want to get up anymore and that I'm stuck, okay? So when you look at it, types of depression and bipolar disorders of the DSM-5. So you go through average mood, major depressive disorder, persistent bipolar 1, bipolar 2, and so you kind of walk through those. And I encourage you, if you haven't already picked it, for one of your papers, this is one of the disorders that you find interesting. So major depressive disorder, 5 or more of the following symptoms during the same 2-week period must represent a change from previous functioning. At least either depressed mood or loss of interest or pleasure must be one of the symptoms. These tests are often, I went to the doctor the other day just for a checkup, and they're going to ask me questions. And I mean, you fill out something quickly, and a lot of those are just really quick to tell you. Number one, we're really testing for like 2 things. Number one, they're going to test for depression a lot, and number 2, are you in poverty and you don't have access to health care and things, and are your living conditions or your socioeconomic position hampering you to get help? Okay, but we're looking for this all the time. Major depressive disorder, so depressed mood most of the day, nearly every day. Markedly diminished interest in pleasure in all or almost all activities most of the day or every day. Weight loss or weight gain, increase or decrease in appetite. Insomnia or hyperinsomnia every day. Psychomotor agitation, retardation nearly every day. Inability to sit still, pacing, pulling, or rubbing the skin. Fatigue, loss of energy. Feelings of worthlessness or excessive or inappropriate guilt. If you can't see there on there, it kind of... my T did not get white there, so. Diminished ability to think or concentrate or indecisiveness. Now, comorbidity, we just went through ADHD. Okay, so you can see the overlap. Reoccurrent thoughts of death, reoccurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. And here's the reality as you get into counseling. A lot of people think about dying. And a lot of people feel sad enough that they wish they were dead. That's not the same thing when you're diagnosing people clinically. Someone just says, well, I just want to die. Well, we're calling it in, hotline. No, I just want to die. I think I'm going to go home and shoot myself. That is all the difference in the world. The ability to formulate the plan or an attempt or that's when we're crossing into these things. The symptoms cause clinically significant impairment. And then, of course, the episode is not attributable to other things and not better explained by another disorder, schizophrenia, delusional disorder, things like that. Going through, though, severity specifiers, single or recurrent, mild, moderate, or severe, once again, the spectrum that we talked about on here. With psychotic features, they'll look at that. In partial remission, full remission, or unspecified. Melancholic, atypical, mood congruent psychotic episodes, anxious distress, major depressive episodes, and meds. And so I got some more videos. I don't have time to show them that are logged in here for. You'll have more videos and information from this. So seriously, and some of these, hey, I live in reality. You're busy, you're writing papers, but at least I'm providing the resource for you to look at later. Okay, I mean, I realize this is more information than one class. I mean, you could do an entire class on depression at a master's level, okay, or anxiety. All right, not to mention the rest, but this is to give you a feel for the jargon, once again, repeating that. So, not going to show you this video, but it's embedded in there as well for sake of time. But it gets into meds, okay, and a lot of the biological foundation for that, so it's good with that. Associated features supporting diagnosis. The disorders associated with high mortality. Suicide. Why do people take their life? Depression. We'll get into all the statistics, but I think you have to go back to 1916 to 1918 after World War I, where you're finding life expectancy decreasing. Except here in the last 5 years it's happened. Why? 2 things. More of us are taking our own lives, and a drug addiction. Now, I don't want us to leave this sad or discouraged. You're taking the class, you want to be in ministry, you want to help people. So, what's the TED Talk? I find those great encouraging videos. Why? People do get better. People can really get victory in this area, okay? And these are secular videos that I'm showing, okay? So you can add on to what they find in Christ with fulfillment and hope and things like that. But I don't know, there's a lot of jobs and ministries you can do in your life. I don't know if there's much better than helping somebody and guide somebody who is depressed or impaired by anxiety or things like that, to really having vitality again. And so be encouraged with that. There are no laboratory tests available for the disorder. So it's always check this, have you done this? I mean, I can't video for your week. You could be with somebody who is depressed, and they could be depressed right now and going through it. So that's the way. Prevalence is 7%. That's not measuring sadness, it's measuring depression. Prevalence is 3 times higher in the 18 to 19-year-old range as compared to 60 plus years. Let that sink in. Who's closer to dying? Obviously.
60 plus, yeah.
Who's more depressed? Yes, that's our society.
Huh.
So, remember we talked about with men, a lot of the ADHD with children, more in boys, things like that. But anxiety was more in what? Females? And depression, prevalent among females, is 1.5 to 3 times higher than in males. Okay. Now I've said this, I think women and females talk about it more. So sometimes be leery of statistics like that. A lady's a lot more inclined in our culture to come in to seek therapy and be diagnosed. A guy can just really hide it. You know, I mentioned my friend who was a sniper with the highway patrol who went later in years for therapy, but he mentioned when he was young with police officers, highway patrolmen specifically, I don't want to mislead, it wasn't police officers, it was highway patrol, but you know, if you killed somebody or you needed help, you went to the model. You weren't going to talk about it. There was a stigma. So anyway. Likelihood of onset increases with puberty. First onset peaks in the 20s, although it's not uncommon later in life. High variability in the course of the disorder. Chronic depressive symptoms increases the likelihood of personality, anxiety, substance use. Recovery begins with 3 months of onset in 40% of clients. They want a quick fix, but it takes work. 80% will fill the recovery within a year. We live in a quick fix society. That's why a lot of people turn to medication quickly. And medication can help with relieve symptoms. The hard work to change the way you're processing takes time. So, risk and prognostic factors, neuroticism, adverse childhood experience, stressful life, all mood disorders increase. I mean, it's that net that spread. Irritability is 40%. In older adults, what it looks like. Switch it. Sometimes older people are depressed, appear to feel tired, have trouble sleeping, or seem grumpy and irritable. Confusion or attention problems caused by depression can sometimes look like Alzheimer's disease or other brain disorders. Older adults also can have more medical conditions such as heart disease, stroke, cancer, which may cause depressive symptoms. Or they may be taking medications with side effects that contribute to depression, and this happens a lot. I was counseling a lady, a senior adult, struggling with grief, and I shared this before in a class, but when she was young, she had lost her husband and her daughter in a pretty short time period. And you think, well, that's what set her off course. No, she had a friend who was close to her who just said innocently enough, but aren't you better, aren't you over this by yet? And that sent her into depression for years. So you think, well, she's recovering from the grief. Not really. It was a depression of being excluded from healthy community and processing it. Well, then what did she turn to as she got older with all pain? More medication. And then by the end, just getting her off the medication and restart it was difficult. Some older adults may experience what doctors call vascular depression, and it may result in blood vessels becoming less flexible. Grief for a long period of time may require treatment, and sometimes we call that complicated grief. And so at our church we have Grief Share, which is a great ministry to help with people with that. MDD-related issues, significant cultural differences in 12-month prevalence rates, but no linkage between specific cultures and the likelihood of symptoms. Higher prevalence in females. Suicide risk for women, risk attempts are higher and risk for completion is lower. It's odd. Men try less often, but what? Finish the task. So going through there. Manic episodes with irritable mood or mixed episodes. Mood disorder due to another medical condition. Substance medication-induced depression or bipolar disorder. Attention deficit hyperactivity disorder. Adjustment disorder with depressed mood and sadness and grief. All going through it. Comorbidity seen with it, substance use disorders, panic disorder, OCD, anorexia, bulimia, borderline personality disorder. First time we've showed up, this will be in the personality disorders that Doug will go over tomorrow. Remember, we look for horses, not zebras, but there you go. Family doctor stated he was sagging into the mental department. King complained months of depression. His wife pointed out he had been having problems with both insomnia and diminished appetite. He denied having suicidal thoughts. No psychiatric symptoms of history of mental illness for him and his family. Does not drink alcohol anymore. These are kind of the teasers that are out there. We look at it. So this is another video, persistent depressive disorder. Not going to take the time, but it's in the PowerPoint. So persistent depressive disorder, one of them that goes on here through that. It's good. It affects nearly 6% of general adult population, can be found in children and adolescents. Combines chronic depressive disorder with dysmetic disorder. Depressed mood for most of the day, for more days than not, is indicated by subjective account. And present, while depressed, one of the two or more of the following: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. Okay? During the 2-year period of the disturbance, the individual has not been without symptoms for more than 2 months at a time. Now let that sink in, that's important. It's a continual thing. Criteria for MDD may be continuously present for 2 years. There's never been a manic or hypomanic episode, and criteria are not met for disorder. Not better explained by another disorder, and symptoms are not attributed to something else. The severity specifier remissions are the same. So early onset before age 21, late onset after age 21. Major depression may precede persistent depressive disorder, and MDD episodes may occur during persistent depressive disorder. Individuals whose symptoms meet criteria for MDD and persistent depressive disorder should be diagnosed with both disorders. And the rest of it is the DSM. Going through it, you're going to find a lot of it with these. I won't do this one here. Difference between the two is severity. Okay, technically, persistent depressive disorder is a pervasive low-level depression that lasts a long time, often a few years. Major depression is a discrete episode of severe depression. When it is gone, the patient is in remission and feels completely normal. So, persuasive, it goes on and on. It's like an onward state of sadness, melancholy, depression. Major depression can hit hard, and you know when you're out of it, if that makes sense. But once again, different than grief. So anyway. Premenstrual dysphoric disorder. At least 5 symptoms must be present in the final week before onset. Start to improve within a few days after the onset. Medicine become absent or minimal in the post-week. Effective liability. What of these items need to be present? So lethargic, changes in appetite, insomnia, must meet criteria for most cycles occurring in the preceding year. Substance abuse, medication-induced depressive disorder. So generally caused by the introduction of a substance. Symptoms begin soon after the use of a substance, and the substance being used can cause the symptoms being observed. Consider whether or not the symptoms were present prior to the use of the substance. Substances such as rheumatoid arthritis medication, asthma meds, illegal steroids, over-the-counter appetite suppressants, things like that. So you can see why people, they go for help, opioids especially, and it leads them into what? The addiction or the depression. But that's pretty easy to diagnose, because what was the big change? You'll find a lot of this with pain medication and addiction. They were fine until they got hooked on that and stuff, going through it. going on here. Let me go through that real quick. Due to a medical condition, depression. So physical exam and lab tests to rule out conditions related to it. Thyroid, hyperthyroid, overactive. You will run across this if you do this long enough, especially with women. All of a sudden the weight gain, all of a sudden they're sad, all of a sudden they're tired, lethargic, and thyroid issue. And most women know to go check that out, but when you're meeting with someone, depending on the age, it's important to check out, to inquire them to do that. Vitamin D deficiency, Cushing's disease, central nervous system issues. These are the things from medical to do it. There's blood tests. How do doctors test you for depression? Okay. Like I said, this is more videos loaded than you could ever see, but especially for those online, I don't want you to just have to keep finding them later. But so to watch, but I do encourage you to. I mean, I know you got to write the papers, but this is one where there's a lot here to go through. So, other specific depressive disorder. You have short duration depressive episodes, recurrent brief depression, and then depressive episodes with insufficient symptoms. Applies to presentations in which symptoms characteristic of a depressive disorder are present but do not meet the criteria for a single depressive disorder. Unspecified depressive disorder, same as other unspecified, except in this case, clinicians choose not to communicate the reason an individual does not meet the criteria. This gets into more of the medical terminology and things like that. Comparison to signs and symptoms of depression and dementia. Okay. Signs and symptoms: onset, depression, sudden, dementia, insidious. The progression: depression, rapid, dementia, slow. With patient history, depression detailed, dementia few details. Effort on testing: depression may be poor, dementia usually good. You can test and see with a lot of tests. Memory improves with cueing, impaired cueing not helpful. There's no recovery for dementia. So with older adults, it's not going to happen. So depression versus bereavement. Mourning can look a lot like depression. It may lead to depressive episodes. In mourning, the external world is diminished in some way, loss of a valuable person. With depression, the self is what feels lost or damaged. I think that's important. With mourning, the world does not seem the same because someone's gone. With depression, I am imploding. A difference. Grief comes in waves, and one can function almost normally in between episodes of pain. There may be some overlap, but obvious precipitating events can help with the diagnosis, as can monitoring the progression of symptoms. Okay. So grief, if it's ongoing sadness after something for an extended period of time, maybe we're not looking at grief anymore. Maybe our grief has transitioned into depression. And just lamenting grief and processing is not going to be what needs to happen. Depression and psychodynamics. Historically seen as an internalized object rage during against the ego related to guilt. So now we're into Freud's world again, going back to theories. Object relation views include relational patterns that are depressive, masochistic, where relations are centralized around provoking rejection and maltreatment. So, depression and cognitive. Thinking determines how people feel and behave. Cognitive organization and structures are key elements of inquiry. Cognition, one's awareness of how one processes information. So this gets into cognitive behavior therapy to treat depression. Cognitive theory, cognitive triad, developed to describe depressed individuals' perceptions. World is devoid of pleasure and others think badly of me. Future is hopeless and not worth pursuing. This goes to what I said yesterday, the inability to construct a future. Self is bad, incompetent, and unable to manage life tasks. Okay, going through that. Depressive cognitive triad, I like this. The bad self, I am worthless. Others are bad, no one likes me. Bad future, what's the use of living? And so that's how the thought processes get in there when you're dealing with people. Of course, you're trying to lead them through questions out of that. So, test assessments for depression, patient health questionnaire, Beck, depression, anxiety. There are tests, inquiry, inventory. There are tests that you can give people. So these are good resources that you'll learn, to have. So it's not completely subjective about how you feel, things like that. And you take them all the time in life. I mean, if you're out and about, and have you thought this lately? Have you done this? Things like that. So anyway, got some more resources on it but for sake of time. So, all righty, let's take just a 5-minute break here after depression. 5 minutes. Then we got 25 minutes, and we'll enter bipolar schizophrenia. So. All right, so I remember treating a client at a church I was at before who did have schizophrenia. And perfect example, he was on medication, and when he was on medication, he was fine. Then periodically someone would come to our church, not our staff, preach, guest speaker, talk about how you need to have faith and not rely on medications. He would go off the medication, much to our objection, and then within weeks he would be back in our office with delusions. And so just a good example of what he needed was the medication. And he was fine when he was on it. And so this is an illustration. Schizophrenia spectrum disorders. So not going to lead you through this for sake of time, but what are your perceptions about schizophrenia? Things come to mind, everything from The Shining, the movie, yeah.
Red rum.
Yes, so all of those things. Bleuler, 1910, Swiss, derived from the Greek word schizo, split, friend mind, schizophrenia mind, the split of the mind, split off from reality. It differs from personality disorders in that it does not represent a split in personality, but in person's perception of reality. Now let that sink in. Okay? It's not like personality disorders. It doesn't represent a split in personality. It represents a split in a person's perception of reality. Okay? So going through here, common misconceptions about schizophrenia. Schizophrenia refers to a split personality or multiple personalities. Fact, multiple personality disorder is a different and much less common disorder than schizophrenia. It is a zebra. Okay. People with schizophrenia do not have split personalities. Rather, they are split off from reality. Med schizophrenia is a rare condition. In fact, schizophrenia is not rare. The lifetime risk of developing schizophrenia is widely accepted to be around 1 in 100.
So schizophrenia is more, like you said, delusions, like the
Yes.
delusions of reality.
Yes.
Okay.
And we'll talk about what's different from that in psychosis. But yeah,
Okay.
is you're splitting off from reality. Like the gentleman I had continually thought this will sound cliche, I promise, it's not, his wife was having affairs. I know this is going to sound cliche and I could misremember this right now, but I think literally there was a milkman. That sounds like very 60s. Yeah, he would imagine it was a split off from reality. There was no evidence of that. That was not happening. But it tormented him, and he did that. So people with schizophrenia are dangerous. Although the delusional thoughts and hallucinations of schizophrenia sometimes lead to violent behavior, most people with schizophrenia are neither violent nor a danger to others. They live in a world that's not real, but it's not like, of course they make movies about the worst, but so.
Yeah.
People with schizophrenia can't be helped. While long-term treatment may be required, the outlook for schizophrenia is far from hopeless. When treated properly, many people with schizophrenia are able to enjoy fulfilling, productive lives. A lot of that is with biological advancement, which we'll look at going through here. The most common early warning signs include depression, social withdrawal, hostility or suspiciousness, extreme reaction to criticism, deterioration of personal hygiene, flat, expressionless gaze, inability to express joy or inappropriate laughter or crying, oversleeping or insomnia, forgetful, unable to concentrate, odd irrational statements, strange use of words or ways of speaking. One guy that I ended up, he was a friend of mine, this is really sad, about my age, and I don't think it was outblown schizophrenia, but he had to be admitted inpatient, very successful, had sold a business, deteriorated, well, he was just depressed, and by the end he thought he had done something that he thought was, to be honest, not abiding by the rules in the industry he was in, and maybe it wasn't. But his delusion got to the point he thought the government was after him. I remember I went and saw him in the psych hospital, and he had worked with a doctor in there and had written some notes down, and he tore them up and threw them in the waste paper can, and then was under the impression that they had come and got them and put them together because the government was going to build a case against him. He would leave it almost like A Beautiful Mind, the movie. He would see people and think they were people that were tailing him. He was going to go back to prison, go to prison for things. So it's, anyway. Daniel's story, Daniel's 21 years old. 6 months ago, he was doing well in college and holding down a part-time job in the stockroom of a local electronics store. But then he began to change, becoming increasingly paranoid and acting out in bizarre ways. First, he became convinced that his professors were out to get him since they didn't appreciate his confusing off-topic classroom rants. Then he told his roommate that the other students were in on the conspiracy soon after he dropped out of school. From there, things get worse. Daniel stopped bathing, shaving, washing his clothes. At work, he became convinced his boss was watching him through surveillance bugs planted in the store screens. And he started hearing voices telling him to find bugs, deactivate them. Things came to a head when he acted on the voices, smashing TV screens and things like that, hospitalized. So. Anyway, nature of schizophrenia and psychosis, an overview. Schizophrenia versus psychosis. Psychosis is a general term to describe a set of symptoms of mental illness that result in strange, bizarre thinking, perception, sight, sound, behaviors, and emotions. Psychosis is a brain-based condition that is made better or worse by environmental factors like drug use and stress. Psychosis is a syndrome that can result from any number of psychotic disorders in the DSM. Okay? So just because somebody is having those doesn't mean they have schizophrenia. There's a lot of things with comorbidity that can be accompanied with psychosis. Depressive disorder with psychosis. Okay? How common is psychosis? One frequently cited statistic is that 1% of the population is diagnosed with schizophrenia in their lifetime. But actually 3.5% of the population experiences psychosis. Hearing voices and seeing things that aren't there are more common than we think. While these experiences may be scary and confusing, it is possible to recover and get better, especially when we tackle issues early. So schizophrenia, a type of psychosis with disturbed thought, perception, language, emotion, and behavior. So, what are the different kinds of psychotic disorders? Conditions that have psychosis as the main symptom are referred to as psychotic disorders. However, psychosis may also occur in a feature of other disorders like bipolar or major depression, right? So you can have psychosis with other disorders, but then there are psychotic disorders. Well, here we go. Schizophrenia, we just went through that. Schizophreniform disorder consists of the same symptoms of schizophrenia, but occurs in a time period of at least 1 month, but no more than 6 months. Schizoaffective disorder is characterized by a persistent symptom of psychosis resembling schizophrenia with additional periodic symptom of mood. Delusional disorder is characterized by irrational or intense beliefs or suspicions, which a person believes to be true. These beliefs may seem outlandish and impossible, bizarre, to fit in the realm of what is possible. Symptoms must be a month or longer. Now, are these pretty easy to diagnose, do you think? They are. But here's where it can be tricky. I had a young counselor one time at another place being supervised, and they were dealing with someone, and the person would come in and was sharing stories of trauma, and they were severe. But I kept hearing this counselor, young counselor, younger, I don't mean young in age, I mean experience working with the person. And after a while, I'm sitting there, and then finally one day they're like, well, something happened in a city, I won't give you the city, and she had worked at a place, and at the place, I can't remember all the details, but there had been rapes, and the manager of the business was in trouble and all these things. I never forgot. I finally sitting thinking, wow, a lot is, and I'm hearing it secondhand, working through the process, supervising. I'm thinking, a lot's happened here. I never forgot. I just told the counselor, go Google that. Googled it. Nothing. And it was a big enough city. I mean, it should have been there. Wait. Not all of this is happening. She's coming in every week with these traumas she's experienced in her life. But upon investigation, it was overwhelming. And I'm not saying things, I've dealt with things, I can't believe all that happened. It's true, but in her case, it wasn't. They were delusional. Okay. So you think, well, yeah, it is easy once you figure it out. But sometimes you could be sitting talking to somebody, and I mean, this is a bad illustration, but I remember my granddaughter would make up funny stories to tell me. Okay. But I remember one day I said, how was school today? And she's not delusional, by the way. So I go, how was it today? And she goes, well, she told me a boy's name, Tommy, not the real name, but she said, he got in trouble. Why? Well, he pushed me off the swing. Like, I'm grandpa. I'm like, what? Yeah, he did. But the teacher talked to him and he got in trouble. And I go, Tommy did that? She goes, yeah. I go, okay. That's not good. So later I'm at the house and her mom's there, and I go, hey, do you know that, Punky Jane got pushed off a swing? I remember her mom just looked at her and goes, Punky did, her name's Audrey, goes, Audrey, did that really happen? Big grin came on her face. And here's the point. She loves telling stories and having fun with me, but what had happened? Instead of a pink rainbow showed up yesterday and a unicorn was on it, this story was what? Believable. Now, she's not delusional. She knew what she was doing. But what makes it difficult sometimes is if the stories are somewhat believable, but a little exaggerated, that's different. So, anyway, looking at it. A brief psychotic disorder includes symptoms of psychosis that last at least 1 day, but no longer a month. Schizotypal disorder, personality disorder, can be easily confused with schizophrenia due to the nature of the people. Schizophrenia versus psychosis. Age. The typical onset of schizophrenia occurs at the age of 18. Psychosis is not necessarily age dependent. Marital status. Individuals with schizophrenia are often unmarried. Onset schizophrenia has an insidious onset where psychosis is typically abrupt. Drug, alcohol, less likely in schizophrenia. I'm not going to read this. The diagnostic criteria of uniform disorder, but delusions, hallucinations, disorganized speech. We have those. That's in the DSM-5. So schizophrenia symptoms. One of the 2 or more of the following symptoms for a significant period of time: delusions, hallucinations, disorganized speech, negative symptoms, functional decline, substantially decreased level of functioning, signs of disturbance persist for at least 6 months, not attributable to the physiological effects of substance abuse or other conditions. If there's a history of autism spectrum disorder, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least 1 month. Okay. Schizophrenia features inappropriate affect, dysphoric mood, depersonalization, derealization, semantic concerns, phobias, hostility, aggression. Schizophrenia development and course. Emergent psychotic features typically occurs between the late teens and mid-30s. Onset prior to adolescence is rare. The peak age for first psychotic episode is early to mid-20s. Males, late 20s for females. Typical onset includes slow, gradual development. The course of outcome of this disorder cannot be readily predicted. The prognosis is favorable in about 20% of those with the illness. However, complete recovery is rare. They will deal with it for a long period of time with medication. Regardless of the degree of recovery, most individuals with the disorder require daily living supports and antipsychotic medication. Okay. You have delusions, hallucinations. I'm going to put that on there to make it easier. Examples include agitation, the basic characteristics of madness, gross misrepresentations of reality. Examples include delusions of grandeur or persecution with my friend, the government's out to get him. His hallucinations experience of sensory events without environmental input. Can involve all senses, but auditory hallucinations are the most common. You hear what? Voices. Okay. Going to go through the positive symptom cluster. Delusions of control. Believing the external forces such as aliens are controlling their minds. Delusions of reference, associating personal meaning to external events. Delusions of persecution, believing that someone is trying to harm or kidnap them. Delusions of grandeur, believing they are someone important like Jesus, or believing they have supernatural powers such as flying. Things like that. So, once again, you're thinking, this is ridiculous. I'll never deal with this. If you do enough counseling, you will. So, should be laughing. Nature of disorganized behavior. Like I said, you could have a whole class just on schizophrenia and paranoia. Schizophrenia, paranoia. A little lower in females. Age of onset is lower with those. Comorbidity. Over 50% of individuals with illness have tobacco disorder. Anxiety, OCD, and panic disorder. Individuals with the illness have a lower life expectancy, weight gain, diabetes, heart-related issues, poor health maintenance. That is for reference later going through it. Delusions, hallucinations. Due to direct physiological effects of general medication, yes. Psychosis due to general medication, no. And you see how you work down to eventually you get to what? Schizophrenia. So this is how you go. So yes, mania or major depression with psychosis, yes or no. And then you go down eventually and you can make the full diagnosis with it. So 1% of worldwide and 1% of the population with schizophrenia. Males and females equally impacted. Females later onset. Onset late adolescence, early adulthood, loss of functioning. So I'm not going to go through all of these disorders. But medical treatment for schizophrenia, this is when psychiatrists or psych hospitals, which would have psychiatrists or doctors, become effective. So historical precursors, ECT, lobotomy, insulin coma, not anymore. Okay. Meds are often the first line of defense. Most meds reduce or eliminate positive symptoms. Acute and permanent Parkinson-like effects are common. Poor compliance is common. They don't want to take the what? Medication, like the story I told you. So part of the inability.
Could some of them think that you're trying to like kill them? Or?
Absolutely.
Okay.
Yeah. Give the pills and hide them. Yeah. Yeah, there's a lot of controls. Like the gentleman I seen, he's in a psych hospital for a reason.
Yeah.
So, yep. So what are your perceptions about bipolar disorder? You definitely want to get through this. So, That's just your paper, right? So, here we go. Bipolar disorder, disruptive mood disorder, has several similar symptoms. Clinicians have been assigning a BD diagnosis to these severely irritable youth to ensure their access to treatment resources and services. However, these children's behaviors are not in case with BD, so we need diagnosis for children to go through it. So, disruptive mood dysregulation disorder, age of onset before 10 years and not diagnosed before 6 years, never more than 1 day in full criteria. Behaviors do not occur during a major depressive episode or are better explained by another disorder. Severe reoccurring temper outbursts, verbal rages, physical aggression to people or property grossly out of proportion. Temper outbursts are inconsistent with developmental level. Outbursts occur on average 3 to more times a week. Mood between outbursts is persistently irritable or angry most of the day. Present for 12 months or more. Diagnosis not made first time prior to age 6 or after 18. Another video, another resource, okay, that for sake of time and those online, but posted it, encourage you to go through it. Bipolar 1 disorder, so here we go. Following criteria must be met for a manic episode. Major depressive episode not required for diagnosis. Manic episode may be followed. Hypomanic or major depressive episode. So manic episode. Abnormally and persistently elevated or irritated mood, increased goal-directed activity energy lasting at least 1 week and present most of the day, nearly every day. B, during mood disturbance and increased activity energy, 3 or more of the following symptoms, 4 if the mood is only irritable, are present in significant degree. Inflated self-esteem, decreased need for sleep, more talkative than usual or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, distractibility, increase in goal-directed activity, socially, educationally, sexually, excessive involvement in activities that have high potential for consequences, engaging in unrestrained buying sprees, sexual indiscretion, or foolish buying investments. Okay, and you can see where this gets into impulsivity and hystericity, which is a later personality disorder. Causes severe and marked impairment in social or occupational functioning, may require hospitalization to prevent harm, or there are psychotic features. Okay, not due to the effects of a substance abuse or medical condition. Note, at least 1 lifetime manic episode is required for bipolar 1 diagnosis. You have to have the episode. Okay. Is worse than depression. At least for depression, there's a floor, and you know it can't get any worse. For manics, the sky's no limit. You just keep going up and up until you lose propulsion and crash. So one's going down, 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 right? Manic depressive, but down, down, down. But at least this is where I stop. Not the other way around. Okay? Not manic. Okay? Bipolar 2 disorder, abnormally and persistently elevated or irritated mood, increased activity, energy lasting at least 4 consecutive days and present most of the day. Same criteria as manic episode. Unequivocal change in individual's functioning. The change is observable by others. The episode is not severe enough to cause marked impairment in life. If there are psychotic features, the episode is by definition manic. Not due to the effects of a substance abuse or medical condition. The severity is not high enough to cause a marked impairment in functioning or hospitalization, and there are no psychotic features. So it'll be, so on your paper, are you doing both 1 and 2, or?
Can I?
You can do whatever you want.
Oh.
I'm
yeah.
flexible.
I'd rather do both.
Well, helps you fill out the paper.
That's what I'm saying.
Sure.
Absolutely.
Yep, and everyone else who hasn't picked one yet, there you go. So, yeah. Here's a deal. Great latitude, I would say, in it.
Yeah.
Major depressive disorder. 5 or more of the following symptoms have been present in the same 2-week period. Depressed mood most of the day. Diminished interest in pleasure. Significant weight loss. Insomnia or hypersomnia every day. Psychomotor agitation. Fatigue or loss of energy. Feelings of worthlessness. Diminished ability to think or concentrate. Reoccurrent thoughts of death. Reoccurrent suicidal ideation without a plan or suicide attempt. bipolar 2. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The episode is not attributable to the physiological effects of a substance or other medication. Note, major depressive episodes are common in bipolar 1 disorder, but are not required for the diagnosis of bipolar 1. Note, responses to significant loss may result in symptoms similar to criteria A in the DSM-5. So anyway, bipolar 2 disorder, so criteria have been met for at least one manic episode. The occurrence of the manic and major depressive episodes is not better explained by schizophrenia of uniform disorder, delusional disorder, or other things. And so have specifiers there. Bipolar disorder features. During a manic episode, clients rarely believe that they are ill or in need of treatment and will often resist treatment. Okay. Clients may alter their personal appearance to be more sexually suggestive or flamboyant. Gambling, antisocial behavior, hostility, lifetime suicidal risk, involuntary hospitalization, legal troubles, financial difficulties, things like that. It's ironic, it's an irony that you usually find one or two extremes. If people actually have bipolar or are in denial that they have it, and then other people, when they can't figure out what's wrong with them, almost seem to cling to it as an excuse. It's just very odd how this works, It's kind of that. So, bipolar 2 disorder, lifetime risk of suicide in individuals with bipolar disorder is 15 times that of the general population, account for 25% of all completed suicides. Wow. They need help. Okay, so. Bipolar development course and risk. Mean age of first onset of episodes about 18 years. In excess of 90% of clients who have a single manic episode will have recurrent mood episodes. About 60% of manic episodes occur immediately before a major depressive episode. Disorder is more common in high-income countries. Separated, divorced, or widowed individuals experience higher rates. History, family history of bipolar is a strong consistent factor. Adult relatives of clients with bipolar 1 or 2 have an average 10 times increased risk. So this is why the medical model kicks in, but at the same time, and I'm going to get into it for sake of time, but the nurture argument comes in. Is it genetic only? Or the sins of the father are perpetuated out of the Bible? It's really not clear. Are we talking about genetic things in our flesh that are passed down, or are we talking about the social environment one's brought up in? Does that make sense? So those are always the things that enter in from theologically. What is mania? Mania is more than just having extra energy to burn. It's a mood disturbance that makes you abnormally energized both physically and mentally. A manic episode can last a week or more. During that time, you may experience grandiose thoughts, take more chances than usual, regardless of the consequences. Mania can be severe enough to require hospitalization. Once again, I hate recommending movies. Please do not judge me. Everyone's got different standards, seriously. But Silver Linings is he's got the manic going. I mean, he's just, I think there's some bad language, but anyway. But you say, why don't you mind that? You sit in an office with people long enough, you'll hear enough bad language. And so, anyway. People with bipolar 1 disorder have at least one episode. Usually manic episodes alternate with periods of major depression. Mania is a high and depression is a low of bipolar 1 disorder. Okay. Hypomania is a milder form of mania, and if you experience hypomania, you have higher than normal energy. Won't get into that too much. Diagnosing it. If you've ever had an episode before, your doctor will take your medical history, perform a physical examination. It's important that you tell them about all the prescription and over-the-counter medications. The symptoms must last at least a week for your doctor to diagnose them. You may also have a break with reality. Psychotic symptoms may include visual hallucinations, auditory hallucinations, delusional thoughts, paranoid thoughts. Mania is a symptom of bipolar 1 disorder. And we'll go through hypomania there. So anyway, all right. So that is bipolar and paranoid schizophrenic. And again, since it laid out in the DSM-5, okay? I know there's a lot there. Session 13, trauma, stress-related disorders. I'll just hit a couple of things here. You will deal with this. We do a lot of work with people, EMDR, things like that. Trauma, stressor related, first responders, EMT, soldiers, abused individuals. Person who is helpless in the face of traumatic experience and has no control. Traumatic experience that continue over a long period of time. The effects of trauma are likely to be more serious if the harm is perpetuated by another person, as opposed to the harm being caused by an impersonal event such as a natural disaster. Let that sink in. If the trauma was caused by someone abusing you, rather than you were in a tornado. Okay. Effects of trauma are at their most severe when perpetuated by a person whose role is to love and protect, especially as a parent. So here you have the trauma from abuse. Okay. Attachment to a protective, loving caregiver provides security and support is a basic need. That's why that hurts so much or hits so much there. The kids who need the most love will ask for it in the most unloving of ways. This is why you got to be careful. The kids who need the most love will ask for it in the most unloving of ways. The child with emotional, physical needs not met, may grow into non-trusting and detached adult. And this is the cycle of abuse. How could somebody who was abused ever abuse another? They don't understand the cycle. Okay? Baby is a need, baby cries, needs not met by caregiver, and trust not developed, disturbed attachment style. So this is where I'll give my personal opinion. Want to be careful. You can disagree. You can always disagree with the instructor. Be careful with the cry it out. Be careful with just let the kid cry and learn and they're growing up. And that came out of, I don't think, the best science from some very fundamentalist preachers in that world. Just be careful. You only have a small window to form the greatest of attachment, and the child needs you, and I know it's an inconvenience, and you can buy into they need to learn to do it and retrain them and all of that. So, okay.
You mean like the self-soothing idea?
Yes.
Yeah. My wife actually, like with Crew, she is, when he cries, she does, because she says, I'm building that trust. And
Yes.
so when she goes and she does, she collects them because it's
Yeah.
the foundation of trust. She just said that.
Yep. And you know what? Hey, people can disagree, but you're just ensuring more business for us later when they're adults. Okay, that was sarcastic, but just be careful. There's a lot of pop psychology things that come out. Just know intuitively what you want to do as a parent. And I'm not saying there's not examples, and yeah, you don't run in there every time they cry, but just intuitively know how God created you as a parent relationally. Trust the instinct, not the inconvenience. Okay, just trust it. Attachment. I've gone through this in other classes. Okay, I've gone through this attachment style, but talking about when we don't have our needs met and the trauma to create it. Reactive attachment disorder. Go through that. Reactive attachment disorder. RAD. What to look for in that area. Let me see. I want to get to, PTSD. I want to look at this one. Post-traumatic stress disorder is a mental health problem that some people develop after experience or witness a lifelong event in combat. It's normal to have upsetting memories. At first, it may be a bit difficult to do activities. Modify criteria. Stressors and actual or threatened death. Criterion, intrusive sense of one of the symptoms. Intrusive memories, distressing dreams, dissociative reactions, flashbacks, intense prolonged distress, psychological reactions to internal and external cues. You go through the criteria, feelings of detachment, estrangement, a lot on this, so I don't have time. Go through the stress disorder. But you will deal with this a lot. And like I said, you have the PowerPoint to go through it for sake of time, and I give it at the list at the end here. But there are help for this, processing pain with people. EMDR, which is kind of difficult as a treatment. Working bad said the amygdala does not know time. That's why we get into trouble. So anyway. All right, so it is a little bit after 4 here. So thank you for online, posted everything. I know it's a lot of information. I know it's a huge I know there's a lot of videos, I know if you go through all of it, but encourage you, it's a resource for later. And again, I'm always available. You could text, you could call, you have a question. It doesn't just have to be an intensive online. I get you could have checked out, gone to the fridge, come back later, missed something. I do not mind helping people. I do not mind emails. We're here to serve. So anyway, I will see you tomorrow morning at 8:30, and Doug will help with some more practical things. So, all right.